Good evening. Good evening, sir.
Good evening. Good evening, Manish.
Good evening.
Somebody. Hello, Dr. Neminathan.
Hello, good evening, good evening. How are you?
All good. How are you?
Fine. Thank
Back
you.
to normal.
Yeah.
Okay.
So,
He's Dr. Manish Mehta.
Manish, good evening.
Yeah.
Good evening,
And Dr.
sir.
Neminathan.
I met you there
organized a
in
wonderful conference at Coimbatore.
Vaccine IDCon.
Yes.
Yeah.
Yeah,
And
you
he
did a very
organized-
wonderful job, very good job.
Even
Yeah,
he
thank
organized
you,
Coimbatore,
sir.
very nice conference just 2 days back. Coimbatore.
Yeah.
Okay.
Okay. Manish, I have not reclaimed host, right? So I am not
Hmm.
host. Now you are the host.
Fine,
So I am
fine.
with PIDA web listen, right?
Understood.
So after finishing it, you should have to stop live
Both the
from
places.
YouTube
Yes.
first,
Okay,
and
fine.
then Zoom.
Understood.
I think this exercise we have to do.
Yeah.
But I think once you are done with this same laptop, no, then they will not ask for the this thing.
OTP.
So we will do it after 7 days, something like once.
Yes. Once we'll do.
Yeah. So okay, fine. So let me log out and join with my Gmail.
Your Gmail, personal Gmail. Yes.
Personal Gmail. Check back. So as Professor, I'll just join.
Hello,
Hello, sir. Good evening.
good evening. Is this okay, the video?
Yes. This is absolutely fine.
Yes.
Yes. Now this is better.
Is better? Yeah.
Yes.
Sir, good evening. Now, Suhas Prabhu, sir.
Hi, namaste.
I am Dr. Neminathan from Coimbatore.
Okay, how nice to see you. You are joined
Nice, sir. Nice to meet you.
early.
How is the outbreak of mumps there in your place, sir? Do you have?
There are a lot of cases here also, but now it is dying down.
Now it is downgoing. Yeah.
Okay.
It was more in March and April. Even February,
Okay.
started in February.
Okay.
March also there were a lot of cases. April ke baad kam ho gaya. Now there are no cases. I have not seen any cases last 2 weeks.
Okay, sir. Probably now it is marching down south. Now we are having on an average 1 to 2 cases per day.
Okay.
Like each and every pediatrician getting 1 to 2 cases, that is still a quite big number.
Yeah, it's a big number. The only problem is we will not really have proper statistics. Baldev was asking kitna case hoga record. I said, people don't even notify. How do you get a correct?
Yeah, the OPD patient
Yeah.
they don't notify. Indoor they may still, but OPD they don't notify.
And the government also does not requires us to notify because they think
not notifiable.
Yeah. Once the government insists, probably they might notify. Government doesn't take this. They take this with a pinch of salt.
No, the other thing is diagnosis so vague. There is, just a clinical diagnosis. So
Yes, sir.
People will report.
Yeah.
What is the reliability?
Yeah.
There are problems. It's not like dengue or something where you have a definite.
Yeah.
Good evening, Prabhu sir.
Good evening, Chetan bhai. Hello. Finally, you called me so many times to do your webinar. Always I had something else. बोला आ वक्ते नहीं कहवानो.
Good that we could catch hold of you.
No, I was free, so why not? I mean, why?
And all the biggies of ID are there.
I think I've told you no at least 3 times before I said yes. ત્રણ વાર તો થઈ ગયો. When something or the other happened and I had to say no to you.
You're
All
traveling
from
for there, no? That's right.
બલદેવભાઈ આવી ગયા?
He'll be joining. I had a word with him.
Okay, okay.
Hello, good evening.
Good evening.
How are you?
Hello, Dr. Shivananda.
How are you, sir?
Namaskara, sir.
How are you?
sir.
Sir, Shivananda sir, good evening, sir.
Good evening,
Good
good
evening.
evening. How are you?
Hare
Fine,
Upendra.
sir.
Hi,
Good
Upendra.
evening, Prabhu sir,
Good evening,
Shivanand
sir.
sir.
Good evening.
Ah,
Good
good
evening,
evening.
Upendra. Good evening.
So all of
Good
you are
evening,
free by
Ganapati
8
sir.
o'clock, 8:40 only.
Good evening, all of you, Dr. Srivas Prabhu,
Hello,
Dr.
sir. How are you, sir? Namaskar, sir.
Namaste.
all of you, Chetan Trivedi sir, Manish
Srinivasan
Kumar,
sir, good evening,
so
sir.
Naminathan, very nice
evening,
to
sir.
see all of you. Doctor,
evening, Shivananda,
of
sir.
course, my
Dr.
old friend,
Hello, Trivedi. How are
Shivananda,
you?
one of the
Shivananda sir,
stalwarts of
can you rename
Parotitis
yourself?
chapter from the
Hello?
beginning.
Shivananda sir, can you rename?
Dr. Upendra ji,
नमस्कार सर, श्रीनिवास
good evening.
सर, इधर
Manish.
के यूएस में
Can you rename on his behalf? Let us just check it out.
Yeah.
Rename means?
नहीं, just let.
उनका नाम आई थिंक मैडम का नाम का आ रहा है.
हाँ.
Is it fine?
Yes, perfect.
Okay, sir.
He did not, Manish, you could do it.
I could do it. I could do it.
Okay, that's it. Sir, we did it, no problem. And now it is Shiva only. Make it Shivananda. Full.
Sir changed, I think.
Yes, sir.
Okay, sir.
Okay, fine. Good evening, Dr. Upendra.
Good evening, Chetan bhai. Kem cho?
After a long time, you are as an academician coming. Rather, every time, otherwise, president.
शिवानंद सर किधर बैंगलोर में ही है?
Where to go? There's no
Half
other
of
place to
them are
go,
on
no?
vacation.
Vacation I go in the month of December, January for 2 months.
I know.
My children place I go. Otherwise, they'll not go anywhere. So all of you are free by this only. It's rare to see people like you to be so free now.
Yes, sir. Now I think after COVID, everybody's evening practice is much early. Everybody, I think,
You close it by early.
early across the country. I think now nobody has 10 and 11 o'clock practice. Abhi nahi gaye.
No,
Those
we
days
close
are
by
over.
8. We close by 8 o'clock.
Yeah. It's not we who decide, patients decide.
You're right, perfectly right in that. They decide themselves.
Yevle sir,
Upendra will be having so many patients mobbing him.
They used to be like that earlier. Now it's not there.
Yeah, I know you have cut down your practice. Yeah.
They are definitely. I'm limiting my practice now. There's no meaning in to continue so many days.
Upendra, why 8 o'clock? I have no patient during daytime also.
Look who is talking.
I don't know what has happened to pediatric practice. What is the, we must ask Shivananda sir, what is the best alternate profession for pediatricians?
Good evening, Baldev bhai. কুন্ডু স্যার কেমন আছে?
ভালো আছি। Good evening, everybody.
Good
Good
evening.
evening. Good evening.
Nice to see
Good
you
evening,
all.
Ridhupura
Good evening.
Kundu.
Good evening. Good evening. Yes.
Jayant is still batting, I suppose. There he comes.
Jayant has joined.
Good evening, sir.
Good evening, Baldev sir.
Good evening, sir.
Shivananda.
Good evening, Dr. Bala.
Namaskar.
Baldev sir.
Yes, good evening, sir.
आपका भी वीडियो बन रहा है।
Dr. Kundu, how are you? Long time.
Fine.
Yeah.
Yes.
Very busy.
Nice to see
Very,
you after a
very
long
busy with
time.
the election campaign. Hot seat.
Good evening, Dr. Shivananda, Dr. Bala, Dr. Suhas, and all the friends.
Baldev ji, Shivananda, Suhas, Prabhu, all.
Baldev sir.
Hello, sir.
Welcome, sir.
If you want to present, like you are going to present the slides, just check it out, no? Can you share it? So that last time we had problem with Dr. Chitkara, sir. Good evening, Dr. Ogila Reddy. Dr. Darur, sir, welcome.
Good evening, Chairperson, sir.
Good evening. Good evening. Good evening.
Good evening, sir.
Is it okay?
Good evening, all, sir. Good evening.
Yes, sir. Perfect.
Chetan, is
Just
it
make it a
okay?
full screen once.
Is it
Yeah.
still okay?
Fine, sir.
Perfect.
Okay, thank you.
Last
Baldev
time
is
Dr.
perfect
Chitkara
in
was
that
on
all the time.
MacBook. That's why that was the problem. Now you can stop sharing, sir.
Yes.
Data. Search data. Good evening,
Data.
Dr. Kiran, ma'am.
Good evening, madam.
Good evening, all.
Good evening, Bala, sir.
Good evening,
Hello,
Chetan.
sir.
Good evening, good evening, sir.
Sir,
Hello,
SB,
ji,
sir.
good
Good
evening.
evening. Good evening, sir.
Hello, Bala sir.
Good evening, sir.
Hi.
Jain bhai.
Dr. Vijay is seen but not heard.
I'm not seen, but
Vijay
I'm
is
heard.
not visible.
Okay, so it is
Hi, Vijay.
sharp
Hello.
9 o'clock. Let us start.
Baldev bhai, namaste.
Sir, namaste.
I think it is 9 o'clock. We will start the meeting. Okay? Yeah. Good evening, everyone. Welcome to this different sort of webinar series, that is current affairs knowledge series. And that this name came just because we had last time we saw so many cases of scarlet fever. And then we thought of doing something different because we have one this webinar series which is already going on, that is a Super 11. That is the brainchild of Dr. Bala sir. Every last Thursday of the month, we are meeting for one topic dedicated to infectious disease. And this time it is going to be a staphylococcal infection various presentation on the last Thursday of this month. It will be moderated by Dr. Kokreja sir. And this is a current affair knowledge series, and there we are going to discuss something which is happening currently. So now what we found, it is not really current, but there is mumps cases. We have seen plenty of mumps cases in last few months, we must say. So when we were putting a name and we were discussing with Dr. Baldev sir, because he is very particular about the data and the definition. So we were thinking, is it a resurgence or something? But it is upsurge of cases. So that's why we put it a upsurge of this mumps cases. And at the same time, there are situations where there is a parotitis, which may or may not be considered as a viral infection, mumps or something else is there. So to cover the whole spectrum and gamut of disease, we just put the name upsurge of mumps as well as parotitis. And who better than be there as a moderator, Dr. Baldev sir. And we have a wonderful panel, the senior most and the most respected Dr. Shivananda sir from Bengaluru. And of course, Dr. Suhas Prabhu from Mumbai, and our own Dr. Upendra sir. He is the academician par excellence, we know that. And lastly, Dr. Jayan Joshi is from Pune. So we have a wonderful moderator with a panel, expert panel, and we have presence of very respected dignitaries from infectious disease. All are screen on screen. So I'm not just taking name, but so I'll just request Dr. Daru Rangnath sir to welcome all, and then we'll start the proceedings.
Hello. Hello.
Yes, sir.
Am I audible, sir?
Yes, sir. Yes, sir.
Very much.
Sir, you all are discussing the cases which belong to the tropical diseases, and the hospital where I worked for 6 years dealt all these diseases what we are discussing now. The upsurge of mumps cases we have occurred, and we noticed that the people who have taken MR vaccine are more prone, and we have collected the information about 100 cases, where the 100 cases out of which are from government setup, where only MR is given, whereas private setup which gives MMR, the incidence is very less. So there was an upsurge of mumps, and at the same time other things also joined it. Once that our scarlet fever has ended, almost now it is not being seen, mumps raised its head, and then now it is dengue that is going on right now in this locality. I want to know what is the position and what was the experiences what they have with mumps or parotid gland enlargement of various causes can be discussed today. I request all the panelists and the moderator to continue and start the session.
Thank you.
Should we
Thank
start?
you so much, Chairperson sir. Now I'll request Dr. Baldev sir to start the meeting. Thank you.
Good evening, friends. I think I've decided not to go for this PowerPoint presentation, but few are there. And let me start with this, because that will mainly project I hope my slide is seen.
Yes, sir.
Yes, sir. Seen, sir. You are clear.
This first slide I kept purposefully, that our ID chapter should be projected. Already I will say well projected, but still its activity. And as Dr. Chetan said in his introductory part, Yes, this is a good concept, that whatever the current situation, and you know that situations are developing, changing, and as a probably custodian of these children and country, we should be aware of it. With this purpose, probably this is well conceptualized, the topic or the one of the, I will say, scientific sessions in the of the current affairs knowledge series. Already it has been introduced that we are going to take the upsurge of these mumps. And I'm sure that all of our concern, when we go for the discussion, we realize that, yes, it is a real issue with us, how we should address it, and how even we can suggest some solutions. For this purpose, we have these learned 4 panelists. I consider myself most fortunate that having the association with all these senior friends for more than 30 years. I remember first time I met Dr. Shivananda in 1984 in Vani Vilas Children's Hospital. And from that day till we have the, I will say, good interactions on the academics. I know that whenever I visit for the medical colleges for the post-graduation, always the students mention Dr. Shivananda as a very good bedside teacher. And I think it is very important in this particular era. We are most fortunate to have Dr. Shivananda as this one of the panelists.
Thank you, thank you, sir.
All of us know Dr. Suhas Prabhu. I think very few friends must be knowing that from the day of his undergraduation to the post-graduation, every time he has shined out. And that shining is continued even in these, I would say, years of his working as a clinician, practitioner, and academician. And we are definitely, will get more ideas, more thoughts on this topic.
Thank you, sir.
Dr. Upendra, all of us know, he's not past president, but immediate past president. That means some still influence is there on the IAP. And we have seen last year that how meticulously he was handling the whole affairs of IAP, particularly the academic affairs. He's very, I would say, prompt, enthusiastic, energetic. Even probably his age is never seen when he's working. And I'm sure that even we'll get these lots of ideas on this topic. Dr. Jayant Joshi, all of us know, senior pediatrician, practicing person, very silent, I will say, grassroots worker, if I say in this era of election of this party of Indian Academy of Pediatrics. And his contribution even in the ID chapter is definitely noteworthy. We know that our association is working, I will say, from day of inception, 1997 in Ahmedabad. We know that very fast developing, still developing, and working very meticulously this chapter. And for that, we have the chairperson, Dr. Darul Ranganathan, very, I will say, silent but methodological person working for this chapter. Chetan, all of us know, really in the Gujarati or Hindi, what we say, in true sense, Chetana is there for every aspect and is, I would say, giving innovative ideas, bringing so many new, even the methodology of gathering the data, knowledge, and even dispersing to all the members. Having this, I would say, information, let me start this business which is allotted to us. We have the 90 minutes. I think 60 minutes will go for this, whatever we have structured the discussion. Of course, there are so many learned members, ID chapter and otherwise, lot many ideas, lot many experiences, even so many suggestions. Please, I'm sure that must be bubbling with you. Please keep with you. At the end of, I would say, 30 minutes or whatever the time permits, we'll take it for the further and try to come to some conclusions, probably which we can suggest to us IAP and through IAP, probably to the government of India. That will be, I will say, our humble efforts. With that, let me start this some of the thoughts which I have. Even later on, we can take from all the members. We know that the recent, probably from October and November, all of us noted that somehow we do come across mumps, even I would say around the year. Every year, sometimes in some months, more numbers of cases. But in October, November, people started to note that, oh, this is something unusual. In a day, 3-4 cases. Some people noted 7-8 cases. And as usual, all of us know that most of the infections, I don't know, but it starts from Kerala. And these, even the mumps cases also first started, this reporting from some districts of Kerala. Later, all of us know, probably all states, almost even Punjab, Gujarat, Maharashtra, Telangana, Rajasthan, probably every corner of the country. I'm not sure if some parties missed or they have not got these mumps. Now with that, my first question, that whatever, first we know that whether this parotid swelling or what are the symptoms, what commonly we are getting, and try to understand whether really it is a mumps or even something else. We'll have to give the thoughts in this way. So let me start from Dr. Suhas Prabhu. Dr. Suhas, can you explain that what type of this scenario with these parotid swellings we have come across in this season? What type of these symptoms or something? And even you can take it simultaneously. Is it indicating mumps or even some other conditions? Can you take that part, please?
Yeah, thank you, Baldev Bhai, and thank you, Chetan Bhai, for finally getting me into this. It's not your fault, it's my fault. I've always said no. But anyway, I think I said one of the things Chetan Bhai will remember, that it will be an honor to be on a panel with Baldev Bhai as the moderator. So anyway, so thank you for asking me the first question. So now in our country, when you see a child with fever and bilateral parotid swellings, we would first think of mumps. But it is very uncommon. This is not the case in the Western countries. While in developed countries, mumps is not the commonest cause of fever with bilateral parotid involvement. There's usually some other virus as a kind of infection that causes. So which are the other viruses that can come like this? I will come back to mumps again. Other viruses that can present like this, and sometimes we do see them, like CMV can cause, CMV virus can cause. We often see patients with HIV who come with bilateral parotitis. You can see it in influenza. Influenza A has been known to have effect with the parotid gland. And very rarely, you do also get bacterial infections, in which case, of course, the child has very high fever, looks very toxic. And a very easy distinguishing factor there is if you press on the Stenson's duct opening in the mouth, you will see a discharge of pus. I have seen only one case in 40 years. I don't know how many of you have seen. So it is not very common. But otherwise, and of course, very rarely you will see tuberculosis. I have seen 2 cases of tuberculosis affecting the parotid gland, but that's almost always unilateral and is of course not an acute illness. But having said all that, I think if you see a child who comes to you with fever and swelling on both sides or at least one side in the parotid gland, our first clinical diagnosis is mumps. And I'm mentioning this because of the fact that most of us almost never attempt to make a confirmed diagnosis by any kind of investigation. So the diagnosis is clinical. So it's very important to think of the so-called differential diagnosis, which are, as I said, much less common than the mumps parotitis. There are rare causes of swelling of the parotid gland. Now, what I'm coming to is really rare. They are not truly infections. You can see parotid gland swelling which as a result of a malignancy. Parotid adenoma is known. And in fact, one of my friends' relatives is getting operated tomorrow for a parotid adenoma, but that is not a child. As a young adult, he is 22 years of age. You can also get a calculus in the parotid gland. I've had one case where we made a diagnosis by doing a scialogram. And you do see bilateral parotid swellings with, that is more of a chronic nature in what we call Mikulicz syndrome, which is of course chronic and sometimes as a part of Sjögren syndrome. So there are a lot of these conditions that present with fever as well as parotid swellings. But having gone through the whole list, my first thought when I see a child with fever and parotoid swellings is mumps. And mumps, as we all know, is due to a virus. It's due to a togaviridae group of virus. And as you rightly said, now we are seeing an outbreak of that, and we'll discuss the reasons for this later. Thank you.
Thank you very much. I think Dr. Suhas Prabhu provided this list of these conditions which may present with the parotitis. Commonly, probably, yes, as a general pediatrician will consider the mumps, and it's not wrong. But suppose due to some unusual presentation or unusual course of the disease, or your unusual way of your other symptoms, we should keep in mind all other possibilities. With this, I think he has made it clear that more likely it is parotitis. My question to Dr. Shivananda, sir, with all these discussions, with this present problem which we are facing with the fever and some other symptoms and parotoid swellings, is it really mumps or should we consider anything else as an outbreak?
Good evening to all. And then at the outset, I thank the organizer for giving us to involve in this very good discussion on mumps. See, there are in our country, whatever the conditions which Dr. Suhas Prabhu said, the first condition should be suspected in a child with a bilateral parotitis or unilateral parotitis or enlargement of the gland is the mumps. But in addition to that, we often see recurrent parotitis. For example, in this season only, I might have seen about 115 children with mumps only within a span of 3 months. Out of that, 7 children had a recurrent parotitis. They came within a span of 2 months, 3 times, 7 children. But in the absence of laboratory investigations to confirm the diagnosis, it's difficult to say that. Only thing is, as far as possible, we have to think of the mumps as a primary diagnosis. Taking the natural history of a mumps, usually most of the mumps, the duration of illness is 3 to 5 days. So naturally, some children have fever, some children may not have a fever. Only thing they will come with a parotitis swelling with a fever. But to confirm the diagnosis is difficult to say. But in addition to that, as Dr. Suhas mentioned, that we often come across cases with adenovirus infection, parainfluenza. We have seen many children, of course, when I was working in HIV the ward, we used to see many children with HIV. That is one of the hallmark of the bilateral parotoid environment is the HIV. That is any child with a malnutrition with the bilateral parotids, you must always suspect HIV. Similarly, we have seen some cases with whatever these 7 children which I saw recurrent parotitis. I could not come to the diagnosis what is that, but all these have a span of 3 to 4 days. They disappeared. They behave like a mumps, but subsequently they came back after some time. So adenovirus and those, unless we do the laboratory investigations, unless we do the Becker swab in or the PCR, then only can able to confirm the diagnosis. Otherwise, most of our conditions will be clinical. We have seen many children, especially in the past, I have seen the children with the salactasis. About 2 or 3 children between 5 to 15 years. One girl is 10 years old, another girl is 12 years old. And then one child with especially the stones in the and in addition to that, some children with a severe PM, we have seen bilateral parotitis. Right. That is one of the that's what is called. We used to discuss with the students salactasia. One of the conditions which you think of that. But in a situation like this, where the number of cases of parotoid enlargement is going on now, based on the clinical examination, we are probably diagnosis is the mumps only. But unless we do the laboratory investigations to confirm the other causes, we have to presume that this is only the mumps. For that, we have a laboratory facilities nowadays now. We have got RT-PCR that is available for adenovirus infection, influenza virus infections. They work out very costly because if you consider the duration of illness, it works out 3 days. Many a time is sometimes taxing the parents Only for clinical interest, you have to do the test. Otherwise, many people may not be able to accept our investigation procedure, because by the time you say that 3 days you have to get the test done, there's a swelling disappears, they don't come back.
Thank you, sir.
So it's difficult to say whether the non-mumps, but you have to kind of keep it in mind. Other non-mumps conditions like viral infections, Coxsackie, flare influenza, CME, and herpes infection, HHV, and a big list of conditions are there. But I don't. In a situation like us, unless we say clinical interest or academic interest, you have to do the investigation. Otherwise, you have to base it on our diagnosis based only on clinical.
Yeah. So I think our both the senior colleagues convey that so many reasons for the parotitis swellings, but most of the times I think it is mumps, and that too when these numbers of the cases that is more likely. Most of the times we have gone with only clinical diagnosis. Is there anybody who has gone, at least may not be all patients, but some patients, some investigation which has confirmed the mumps? I think out of these all 4 panelists, whether anybody has any experience, probably if you have not done, but you have heard your friend has done.
Yes. So can I share?
Yes, Upendra. I think that's the thing which I was waiting. Please.
Yeah. Very good evening, and thank you, Dr. Raghunath Dararu and Chetan, for your kind invitation to be here in this wonderful program with the august company of these wonderful senior colleagues. So coming back to the topic of mumps and talking about the laboratory investigations, all of us, I think each one of us who are in practice more than 30 years, we are all been doing only a clinical diagnosis. And though Dr. Prabhu and Dr. Shivananda have elaborated on the various causes of parotitis, I think when it comes to epidemic parotitis, the only cause remains, I think mumps is the only cause all over the world when you talk about epidemic parotitis. So we stop there, and we know that even if I do investigate, I'm not going to offer any treatment. It is going to be all right in a couple of days, maybe. So that's why probably we do not think much about it. But now the time has come probably, and when we want to show, we will come over to that topic that government, why are you not putting the mumps part in the MR component of the vaccine? They tell us, ask us what is the data, how many complications have you seen? So let me share that one of a very, though not myself, but this current epidemic of last 3 months from January to March. So one of my colleague, all of you know, maybe knowing him, Dr. Jitendra Gavane, who is an associate professor at MGM Hospital. So they had 8 cases of meningoencephalitis, not 1, not 2, and all 8 have been investigated, and they have shown CSF positivity of IgM. So PCR, sorry. So that is how they have diagnosed the mumps. So now there is a clear-cut evidence, but we do not do. But when it comes to complication, probably that is the time that all of us need to start. When we all started practice, Dr. Prabhu, you, me, I think we all had aseptic meningitis, and we always thought that it is mumps unless fluid otherwise, and the patients used to become all right. Aseptic meningitis, we never bothered much. Right. But now the time probably as and when we see complications, we have just discussed about parotitis part of it. When a child comes with any of the complications of mumps, I think we need to do investigation. Yes. And there are various investigations. I think if you
I think that part will go later on.
Okay, fine.
But I think what we learned from Dr. Upendra, and I also tried to learn. Please, those who are not speaking, keep yourself muted. Dr. Neminath. So what we gather the information that routinely we don't go for uncomplicated or simple cases of the mumps, but if they go for some complication, particularly CNS or some others, they have gone for these investigations, some of the friends, and I gathered the information, not exact data, but they got this, even the evidence of the presence of mumps. Even already I have one patient in my unit with the GBS. That part is something new, but the patient had 2 months back these mumps, documented mumps by the pediatrician, not investigated, and that presented. And similarly, 3-4 patients with a meningoencephalitis had some other even ICU units, we got it. So what I gathered the information that not all the patients are investigated, but with the complication, whatever the numbers of the investigations have been performed, they have shown the presence of the mumps. And therefore, I think we consider at present that these outbreaks, what we are, and what Dr. Upendra said is right, that any even this type of the epidemic or outbreak, even in developed countries, they consider that this type of this presentation should be with mumps. I think Dr. Suhas was raising the hand to add something. Dr. Suhas? Dr. Suhas, you are muted. Dr. Suhas, unmute yourself.
Okay. I wanted to add something.
Yes, yes.
Sometimes you are confused whether it's a salivary gland swelling or not. Because that's the issue. You have to identify it. Parotitis is easy to identify. But sometimes it is the submandibular gland.
Dr. Suhas, we are coming to that point after some time, please.
Okay,
Thank you. Thank you. Because I will have to keep in mind 60 minutes also.
Okay.
Anyway, I think with that, Dr. Upendra, you can take it that something information on this, the virus, mumps virus. I'm sure maybe the basics, but very important. What type of the virus, infective period, or probably that would be useful that which children should be isolated for how many days. From this point of view, can you take some basics of the virus, please?
Yeah, I think we should have some basic understanding of this virus. All of us know that it's acute and highly contagious viral illness, and it's caused by this single-stranded RNA paramyxovirus. All of us know. The basic thing about mumps is it's almost always a sudden onset. So that is very important. There is only one serotype, fortunately, but there are more than 13 genotypes. So genotype variants, and they come into picture when we talk about vaccines. So it may not come for identifying the disease per se, but for vaccines, it makes a lot of difference. And humans are the only host, fortunately. Also, there was some question about bats also having certain, but then by and large, it is considered humans are the only host primarily. And single attack usually confers lifelong protection. So that is what the presumption is always. The number of complications, all of us know, we have just been talking about only parotitis as of now, but each one of us has seen probably.
I think, Dr. Upendra, that manifestations and complications will go later.
Yeah,
regarding this infectivity, incubation period.
So two important things, that incubation period, I think 16 to 18 days.
Right.
And infectivity, very important to know that 2 days before the onset of parotitis and 5 days after it. So when a child is not supposed to go to school is at least 5 days after onset of parotitis. But having said that, it is considered that in saliva, the presence of mumps virus is 7 days before and 7 days. So maybe 7 days is an extremely safe period, but 5 days you may consider. So these are the practical points one should keep in mind while talking about mumps virus.
I think Dr. Upendra talked very important points. Number one, that this is the one serotype, but the genotypes are many. And many times probably we are not aware of it. And it is important probably in the subsequent discussion. Very important point, practical, many friends are asking or even the parents are asking. So once a child develops these mumps, for how many days child should not be allowed to go to the school? I think that is most practical. And what he said that is salivary secretions may be containing the virus for a long time, but usually it is considered infective period. I think before this swelling, we don't know how many days, but at least after the development of the swelling, 5 to 7 days. And I think that's a time which we can keep in mind for not allowing the child to go to school or with the contact with other children. I think with this, let me take the further discussion with the Dr. Jayant. So then simply you can take this, that how clinically it is manifested, these mumps, and even some other nearby conditions which we'll have to differentiate.
Yeah.
But really it is the submandibular gland or something else.
So at the outset, let me first thank Dr. Chetan and Dr. Dararu sir for the opportunity, and my greetings to all the senior panelists on the panel. And coming to the discussion, I think what Dr. Suhas mentioned about it, the clinical presentation, and as Dr. Upendra mentioned, is always an acute presentation. You will have a fever with a parotid swelling, either unilateral or bilateral. Now, in a classic unvaccinated child, you probably would get full-blown picture of the mumps disease, which would manifest in the form of high-grade fever, which would be short duration, 2 or 3 days, and there would be associated typical viral prodromal features, like you can have a little bit of vomiting, you can have body pain, you can have headache, and sometimes even a headache which is precipitated by vomiting. So all that thing can happen. The parotid swelling may appear a little later. Now the key point here is to know is that, as Dr. Upendra mentioned, the infectivity begins before the appearance of parotitis. So that is the time when the child is not being isolated, and that is the reason why, because the child is being actively involved with other playgroup or school people, everything, the chance of infectivity is very high. So parotid swelling, though it's a very reliable feature, it can also have a variable presentation. It can be unilateral, it can be bilateral. Sometimes you can have other salivary glands also involved, like in the form of submandibular glands. And you can also have, if you have, like in a typical case, you would have a viral like cell illness, the parotid swelling would last for about a week or so and would regress on its own. And most of the times you will see now, when we practice in the little bit of periphery, you see that, casually the children come with a bandage put on a parotid swelling. And it has been a traditional village household therapy for this thing. It is just nothing but to just assure them that it is a time-related recovery of 1 week or so. Now, most of the times, since you mentioned, sir, that this is something which gets better on its own and does not have any specific treatment, in our private practice, we don't see too many of them coming back to us unless they come with a presentation of complication.
Yeah. I think, Dr. Swas, what you were describing, can you differentiate the parotid swelling and swelling to submandibular gland or some other conditions?
Yeah, I think the confusion is more when you have, for example, a submandibular gland, because then you think whether it's a lymph node.
Correct.
So I have two very simple suggestions to try and, if you can't clinically differentiate, one is to get a serum amylase, which is always elevated when the parotid gland or the salivary glands are enlarged. A second is a sonography. Now, sonography will, of course, clearly identify a lymph node and separate it from a salivary gland. A good sonographer can tell you that. I also wanted to add one more thing, is that it is estimated that about 1/3 of patients with parotitis, with mumps infection, don't actually get salivary gland involvement. That is, they don't have any swellings at all. So we should not be surprised if you find, for example, a pancreatitis or a meningoencephalitis coming, and you say, oh, this fellow never clinically had mumps before that, but yet it can still be mumps, which has come now directly with a complication without any salivary gland involvement earlier. Thank you.
I think one very important point, I'm sure that, yes, Dr. Shivananda, please.
No, sometimes the posterior cervical lymph nodes, diffuse enlargement of the posterior cervical lymph nodes also mimic the parotid enlargement. Clinically, what we can do is, if you look at the elevation of especially the earlobe, that always indicate the child is having a parotid enlargement. So that's one of the important things, because this is a parotid enlargement clinically is a diffuse swelling. You can't delineate the lymph node as you see that it's like a what is called a fluctuating swelling, especially the surrounding the parotid. That's a clinical marker of the importance of clinical examination, where elevation of the ear lobules,
absolutely,
that diffuse enlargement of the parotid, especially post cervical lymph node, that has to be mistaken as especially mumps, and then the people may start considering as a treatment for mumps, and they may not put. They may not treat submandibular or posterior cervical lymphnopathy.
Yeah.
So that has to be kept in mind.
Yes, sir. I think very, very important points are what sir brought out clinically, that in the case of parotid swelling, the ear lobule will be upwards and even the forward projected. That is a very important clinical side. Of course, as Dr. Swasprabhu mentioned, nowadays with the sonography, I think when we were students, without the sonography, we were learning. But of course, even this now, amylase, even it becomes also direct evidences. So these are the important. Yes, Dr. Upendra, you
no, I just one
something.
simple clinical test also. If you have any doubt, a child, if he has something sour, if he think that the
even
pain
increases,
intense, extremely high pain after drinking anything.
Yes.
We have. It is also other point is, whenever the child is having a recurrent parotitis, suppose the child sees a sweet, immediately the swelling of the parotid glands. That I've seen clinically that, especially recurrent parotitis in children, and that especially the test can be done is put a sweet in front of the child, you can see the swelling of the parotids and disappear within no time.
Right. Dr. Jain, you wanted to say something?
Another important thing is that when you have a parotitis coming out of mumps, it is always a diffuse parotid involvement. So one would probably, if you see the anatomical location of the parotid gland, which comes from the, if you take a vertical line from the ear, and if you take it below, probably the parotid gland would be dividing that line. Suppose you have an enlargement, it would be always a diffuse enlargement. It would not be a unisided or one-sided enlargement. And that is one important point to distinguish, that your posterior cervical lymphadenopathy will be a little behind. So that kind of thing, of course, a very big parotid swelling will lift the earlobe, as Dr. Shivananda sir explained.
Absolutely.
But if you have a little moderate swelling, this is one way to know whether the swelling is diffuse and whether the swelling is slightly behind. In posterior cervical lymphadenopathy, you will have probably a little swelling which is behind the node.
I think one more point, Dr. Suhas. Some people say that even not necessarily always it can be bilateral, even unilateral. So in actually experience or what they convey, that how many patients you may get even unilateral, because whenever unilateral probably it may create some more confusion. If bilateral probably obviously will say yes, it is mumps. So can you take this point?
You're asking me, Dr. Baldev?
Yes, Dr. Suhas.
It's about the book says 70 to 80% as bilateral. So that still means 20% or 1 in 5 or 1 in 4 cases you can have swelling only on one side.
Right.
Sometimes the patient presents with swelling only on one side to come 2 days later with the swelling on both sides. So that can also happen. If he comes a little early, you see the swelling only on one side. So it can happen.
Yeah.
So
Dr. Shivananda, yes, yeah.
See, I just tabulated about the 115 cases which we saw in the last 3 months. 62 patients out of 115 were unilateral. And then bilateral 33. And submandible involved in 11 only. So it all depends upon the... and then in addition to that, as Jain mentioned that, only the out of 115 children, 78 had not been immunized. They are given MR vaccine, and 14 children had 2 doses, and nearly 23 children had single dose. So, in the presence of history of especially immunization history is more important when you differentiate the parotitis enlargement by other conditions.
Yeah, so I think history of vaccination is also very important. I think we'll have to go further. I'm looking at this.
One submission.
Watch also. Yes, sir. Please.
One submission, sir.
Yes, Dr. Daru, please.
Sir, the child comes to you with the enlarged or swollen cheeks. We have to examine him from the backside to look for the elevation. Prior to that, if you see by the side, obliteration of the retromandibular space is the earliest. Yeah. See, these 2 points should be examined.
Absolutely.
And if it's an enlarged swelling, then try to palpate for the borders. You will never be able to palpate the borders of parotitis. Plus, if you are able to delineate any mass there, it is not parotitis, it is a lymph node, infra-auricular. So these are the basic things, sir.
Absolutely.
Plus, you have, sir, this plus the throat has to be seen. Otherwise, you may miss a bull neck diphtheria.
Yeah.
This is our practical experience in fever hospital, that is tropical disease hospital.
Thank you, sir. Very important. So I think 2-3 points we can keep in mind. That's some obliteration of the angle of this mandible, or even the swelling, if you see from the back, even the elevation and outward protrusion of the ear lobule. Very important point that the sharp demarcation may not be possible in the parotitis swelling. If demarcation probably more favors the lymph nodes or something, and even they may be unilateral or bilateral, but what Dr. Shivananda said in his series, I think single person, more than 100 cases. And that too significant, he saw the unilateral. So I think unilateral, bilateral may not be important. That as a clinician we can keep in mind. And regarding some food and salivation and pain and even examination of stents and duct and inflammation, I think all these points may be useful for the clinical consideration of the parotitis swellings and more of the mumps. Now I'm coming to the Dr. Upendra, to you. As already we discussed, as we are good clinician considering ourselves, and therefore hardly we'll go for the investigation. But suppose if at all, we want to go, or even we want to prove, what are the investigations available specifically for the mumps?
So there are 3 investigations that one should remember that which are available. And when you call something as an outbreak, how do we define it? More than 2 epidemiologically linked cases with at least one being diagnosed, confirmed, lab confirmed within 25 days of occurrence of the first case. That is what is a definition of an mumps outbreak is. So we have 3 tests. I think one test is blood specimen for the antigen antibody, the IgM response, that is what is seen. Swab of buccal mucosa for viral replication that we see, detection of virus. And of course, the urine specimen for again viral detection. But out of which two tests which are common and which are easily available, I think, is the blood test and the buccal mucosa PCR test. So it is considered that if it is, and of course, it will be huge difference between a child who is vaccinated and how the test would come and one who is not vaccinated. I'll just elaborate a little bit about the IgM IgG response. The IgM response, which is usually all of us know, is the first to come up in an unvaccinated child. In a vaccinated child, the IgM response is small, but IgG response immediately picks up. So to demonstrate a fourfold rise in a plain and as well as after a week or two doing the convalescent sera and then showing the rise in antibody titer is almost impossible. And it is the IgG which takes precedence over IgM in a vaccinated child. That is number one. Number two, it is considered that in early first 3 days, if you can send us a scraping of the buccal mucosa for the PCR test, probably that becomes the best test initially to offer. And after 3 days, maybe you can do the IgM test. But in an unvaccinated child, vaccinated, as I said, it will be extremely difficult to differentiate. And finally, the urine test, it is considered, but I felt, and I could not see anywhere that urine antibody testing has been done or even a PCR test being done for detection. So basically, it comes to serology of IgM, IgG, and the PCR detection. I think this is what is it. But when you go about complications and then you want a sample from other places, like we just talked about the CSF PCR, that comes when a child with complication comes, meningoencephalitis, basic, which is the one commonest complication that we come across. And rest of the corroborative evidences like raised amylase or other things, I think they do not give directly, you may not be able to count it as a mumps case, but for diagnosis and demonstration, these are the two tests which are commonly done.
Yeah, I think very important what he said, that serological test may not be that useful, but definitely there's some evidences of the virus you can consider. And very important is the vaccination status for the interpretation of this antibody, particularly the IgG, what already Dr. Upendra mentioned. Probably with the complications, certainly anybody is going to go for the specific investigations. And for CNS, I think CSF PCR is very, very important. With the pancreatitis, all of us know that even lipase, beside the amylase and other investigations, which will be helpful to us. So routinely, probably we may not go, but yes, I think in this type of the outbreaks or epidemics, at least to prove what Dr. Upendra mentioned, that some of the patients, we should have the proof that yes, it is due to the mumps epidemic or so. Anyway, I think Dr. Suhas, again, I'm back to you. What can be the various differentials with the parotitis swellings? Again, probably some of them you have mentioned, but important for, I will say, the tropical pediatrician or pediatrician from our country.
No, I think I've gone through that list of other viruses that can present, but they are much, much less common.
I think from that, what I wanted from you, because how much the EBV virus is considered for this parotitis swelling?
EB virus is general.
That is not uncommon in our practice.
No, but EB virus has a, see, remember, the problem with the mumps virus or the predilection is for epithelial linings. So that is why it affects the epithelium of the parotid gland. So therefore you get parotitis. The pancreatic duct, therefore you get pancreatitis. The lining of the meninges, so you get meningitis. And the reason why you get the virus in the urine is because the virus has a predilection for the epithelium of the urinary tubules. So that is the reason why you get it. So whereas the EBV has a very different predilection. It is primarily affecting the lymph nodes. And therefore, I don't think you will get parotid swellings in an EBV case. The confusion might occur because you have mistaken the lymph node for a parotid gland.
Right.
I think we had such nice explanations from how you can clinically also distinguish between the two. And as I mentioned, a very simple thing to do is an amylase test, which is easily available. So I would not include EBV in that. I think Dr. Shivananda also mentioned some other causes of parotid enlargement that can present. If you look at chronic cases, then yes, there is recurrent parotitis of childhood, which we don't know anything about. You can see it, for example, in sarcoidosis. I've seen 2 cases of sarcoidosis which had parotitis, not as the sole presentation, but they also had parotitis. And of course, sometimes you don't find any reason at all. I have had a couple of cases where they had chronic non-specific parotitis. I couldn't identify any reason at all. But I think acute cases are, as I mentioned, viral infections and sometimes bacterial infections unilateral in tuberculosis, occasionally calculus, and rarely tumors. And
Thank
of
you,
course,
sir.
that's part of Mikulicz or Sjogren syndrome.
Yeah, I think systemic autoimmune disorders also we'll have to keep in mind what you mentioned. Yeah. I think now we'll move to this.
To complete the list,
yes,
Dr.
sir. Yes, sir.
To complete the list, you must also think of sometimes lymphangioma may be present there only. And then meningioma also should be there in that situation.
Yes, yes.
And you must never forget pre-auricular lymph nodes, diffuse swelling of the pre-auricular acute, the lymph node enlargement may be confused as parotitis.
Yeah.
Especially there are two types of two layers of lymph node in the parotid area, superficial lymph node and deep lymph nodes. If they get infection because of the virus, or maybe suppose you get adenovirus infection or retrovirus infection, maybe due to the enlargement of the lymph nodes in the parotid gland. That may access a parotid enlargement and may be mistaken as parotitis. So that has to be kept in mind before you close it up. And in addition to that, sometimes you may get a ranula. You may also get some of the conditions like mixed parotid tumor, as you used to see earlier days, especially when used to be in the house, especially house surgeons. And then nowadays we don't see that. And a malignancy, as Dr. Prabhu mentioned, adenoma. And cell adenitis and cell adenosis is also one of the conditions that should be kept in mind.
Thank you, sir. Thank you. I think all of us know that why the government is not accepting mumps vaccine, because they said don't.
I want to add something, sir.
Yes, sir. Sir, please.
There will be no nasal discharge. There will be no conjunctivitis.
Right.
There is no oral discharge under any circumstances in a case of mumps.
Yeah,
this is another discussion.
Yes, sir. Yes, sir. We know that as per the burden of the disease, probably now we will be in the position to provide them. In the past also we have done. And second argument, I would say from this authority that this disease is usually benign. There is no complication. But I think it's not that straightforward. Dr. Upendra, can you take it? That what complications are known, and specifically, I think individual, all the panelists one by one, whatever you have come across, or you have gathered the information from your friends. Dr. Upendra, please.
Yeah, I think Dr. Prabhu has already mentioned the basic thing, the predilection of this virus to the epithelial glandular cells. So that's why it goes to salivary gland. That's why it goes to the parotid gland. That's why it goes to the testes. That's why it goes to the urinary tract. So that is how, and meningoencephalitis, everything. So the common complications which we have seen, I think at least one case that I have seen is orchitis. These are all usually post-pubertal boys that we see. I must share one case of euphoritis, which my wife is a gynecologist, and she had a patient, 17-year-old, excruciating pain in the right iliac fossa, clinically rebound tenderness, so appendicitis. And these are the days much before early days in our practice. And then we said surgical opinion, probably this will require exploration. And then somehow the patient went back, and then the history said that last week she had such swelling, and then probably thought of mumps, and then amylase came that time also positive. So a surgery was avoided. So sometimes the excruciating pain in the right iliac fossa, and then ultimate diagnosis as euphoritis. That is what is a personal experience that I would like to share. And of course, meningoencephalitis, all of us, aseptic meningitis. Fortunately, pancreatitis, epigastric pain that has been seen. These are the complications that I have personally seen. I have not seen any child with a nephritis, myocarditis, or a paralysis, or a Guillain-Barré syndrome that sir was talking about, a cranial nerve palsy, hydrocephalus, though they are all been reported. But these are the complications that I have seen that I must talk about: orchitis, euphoritis, pancreatitis, and aseptic meningitis.
Right. Dr. Jayant,
during our Vanivelas days, we have come across one child with a pancreatitis, another child with a orchitis.
Yeah.
Subsequently, I have not seen the complications.
Right. Dr. Jayant?
Yes, sir.
Any complication which you would like to mention, either you have come across or gathered from some other your friends or institutions?
Yes. I mean, like Dr. mentioned and other speakers mentioned, in Pune, I got the information from various government hospitals. And in the last 3 months, there have been more than 8 to 10 cases of meningoencephalitis being hospitalized. And most of them have presented with a headache. Some have a sign of meningeal irritation in the form of vomiting and altered sensorium. None have got convulsions. And when they were investigated, all of them were found to have pleocytosis. In all of the cases, the CSF RT-PCR was done and it isolated mumps virus. So it's a conclusive. Interesting thing is that in 2 of the patients, the parotitis swelling appeared later. So sometimes you can have meningoencephalitis coming at the onset of the disease. And as I could recollect, I think Dr. Prabhu sir will also agree, my teacher, Dr. Ajay Joshi, used to often tell me that when you have an intense headache in a middle-year-old child, middle year means 5 to 8-year-old child, and there is a little bit of fever, and if you are thinking of some kind of a meningeal involvement, that time we used to do the CSF examination very often, and just to rule out anything, and you do a CSF, and sometimes just doing a procedure of CSF is relieving act for the child, because it immediately reduces the pressure and it takes care of the headache and everything. The child is sitting up in the bed and practically feeling as if there was nothing wrong with the child. So here the CSF was being done only for diagnostic purpose. But now with this meningoencephalitis, I have seen a child who also had persistent symptoms. We required to give sodium chloride for reducing the increase in cranial tension, and the child continued to have a little delirious activity. The amylase continued to remain very high, and the child isolated, of course. It took almost 5 to 7 days for the child to come down to normal. And as you said, orchitis, I have seen only one child of orchitis that was around 15 years old child. It was again that orchitis, it was a tender swelling, but again amylase was supportive, but nothing else we could do. But I did not see that child again. Interestingly, why I was under the impression that this orchitis would cause a testicular atrophy and probably would contribute to a sterility. What I have found out from the research and literature is that probably the sterility part is not so consistent as what now everyone perceives. Because when we were postgraduates, we were told why it is so important is because the damage caused by orchitis, the testicular damage is almost always permanent. And that is the reason it is important not to miss it. Upsurge, as Dr. Upendra mentioned, I have also seen one child of upsurge where appendicitis was a differential. Luckily, because of the amylase, we were saved. Of course, that child had an existent swelling. So again, it's very important to know the acute abdomen. Dr. Mankar, who is an ID specialist in Pune, shared one case with me where the child had intractable vomiting, and it appeared like viral gastritis. I'm like initially given some ondansetron, given something, nothing worked. Finally, the child was hospitalized and given parenteral IV fluids and then IV ondansetron. The child settled down eventually, but the point is, on the 3rd day, developed the parotitis swelling.
Right.
And there was a marked tenderness. The amylase was there, but the lipase was not raised. Again, the ultrasonography done for the abdomen was not very conclusive, so it could not really say whether it was a pancreatitis, but the child settled over a period of 2 to 3 days just on the measure of anti-emetic and other measures.
Okay.
Thank you.
Baldev,
Yes,
the CSF glucose should be kept in mind when you are interpreting meningoencephalitis.
Yeah.
We had a child who had only low CSF glucose and thought of a bacterial cause ultimately. And Jayant very rightly said the parotitis can come before, during, and after. CNS can anytime be affected, and we should be taking care of that low CSF glucose in some patients of mumps.
This is very important point Upendra has said, because
Dr. Jayant, I will have to keep in time.
Okay,
so
sure.
let me share some of the points which I have gathered. This is from our GCS Medical College. I think it is interesting to see that even the 39, 50, this even the 33 years, because I have taken the data from all the departments, and these were diagnosed as the mumps. And again, I think this was in current month, in the January, February, you can see the 64 years. You can see the 24, 30 years even, besides the children of even the 4 years and 8 years. And these were the patients of the mumps from our medical college. If you see even nearby our college, there is one municipal medical college, that is Shardabed Hospital. They have prepared one paper of 115 cases. And what they shared, that younger the children raised, but 2 to 10 years they got most of the patients. They have not gone beyond this pediatric age group. Therefore, he said that that is not in the data, but otherwise in the medicine, they got the adult patients also. If you see complications, I think 2 patients they came across for the orchitis, and most of the other patients were non-complicated. This is my request I got from the Municipal Corporation Ahmedabad, not the more details, but at least more than 700 cases from January to May they have got, and we know that the data is not always, I think it's an iceberg. Many patients, I would say, they are not reported because we are reporters and we know our situation. So that was regarding the corporation. But again, if you see last April 2024, I'm talking, there is one article from this Gorakhpur AIMS, that is a recent surge in the mumps cases in India, and they have gone in details. More, I would say, almost they mentioned that every corner of our country, they got the cases, and they're not in thousands. Only Kerala, they mentioned probably more than 6,000 cases in the last few months. And even what Dr. Shivananda sir was mentioning, only one practitioner, that too senior practitioner. Probably we know that the practice he might be doing the practice for fixed hours, but still more than 100 cases. So definitely I will say significant numbers of the cases. Even if you look at this published article in 2015, when this MR vaccine was introduced by the government of India, and our Indian Academy of Pediatrics gathered the information, they analyzed, and they even conveyed to this government that this is different centers. You can see Calicut, Trivandrum, Sangli, Manipal, Pulwama, even from the Kashmir, Calcutta. So many numbers of cases they are noted. I will say some 100, 300, more than 100. And even if you look at the other places, Chennai, Usmanabad, Ludhiana, that means across the country during that time also. And every 5 to 6 years when we are getting this repeated. Encephalitis point of view, even if you see these numbers of cases, they got some 5 cases of mumps encephalomyelitis from Lucknow, some 6 cases of mumps meningoencephalitis from Delhi, and even from the Aligarh, some 9 cases, and 138 cases of meningoencephalitis. Out of 1,500 cases of acute encephalitis syndrome, they got due to the mumps. So I think this type of data, documents, published data is available in, I will say, in our literature also. Almost this is in some other way they have shown. This is by the ID surveillance portal of our Indian Academy of Pediatrics, which were probably we are supposed to report. We know that hardly we report, but that figure also is showing some 477 cases in some span of probably few months. Similarly, 143 cases later on. Somehow they mentioned that most of the patients were unimmunized, 84% and 61%. So I think that was the data regarding even some of the centers which are already available to me from the literature. I think few points regarding these management. Dr. Jayant, can you take it? Probably not much in the management, but later on we can go to the important points of the discussion. A line or so.
In a uncomplicated mumps, a child probably would have an uneventful course over a period of 7 or 8 days. All you require is just supportive management. And if there is a little bit of pain at the site of parotid gland, or if there is an accompanying fever, paracetamol is the only alternative. Sometimes you can have an onset coming with vomiting, where you would require to use antiemetics for the control of vomiting. And as I mentioned, if there could be an association of gastritis with that, we will have to take care of the supportive management. But more often than not, we have to be watchful about development of complications. One important dicey thing regarding mumps is that there is no established correlation for the complications to develop after the disease. You can have parotitis coming at later stage. You can, the child directly presenting with the complication. Regard, there are factors on which we can work. For example, a parotid swelling, or as Dr. Prabhu sir mentioned about doing an amylase.
Yeah. Anyway, I think Dr. Jayant has mentioned this treatment part, and his network it also does not allow him to speak more. No problem. I think he decided that, okay, it is sufficient. Now, Dr. Suhas, I'm coming to you for the very important, I will say, point which people are keen to know. That it is known in these type of infections, measles, dengue, mumps, that at certain interval, these type of some resurgence or outbreaks or some more number of the cases may be there. So I think, is it so for these mumps also this year, this time which we are facing, or even some other regions? What are the likely reasons for this upsurge or more numbers of the cases of the mumps this time?
No, I think most viral infections, whether it's dengue, whether it's measles, whether it's mumps, seem to have cycles. Even influenza has cycles. Every 3 or 4 or 5 years, you start getting a peak. I do believe this year's epidemic of mumps, if you can call it an epidemic, if you just want to call it an upsurge, whatever, is partly because of the fact that the government does not include the mumps vaccine, but also the fact that I do believe that in the COVID years, even the MMR vaccine in the private sector must have suffered. So the number of children who are non-immune must have gone high, and that's possibly the reason for this outbreak. So these are the only reasons that I can think of.
Dr. Swaz, is it so, as Dr. Upendra was mentioning, there are some different genotypes? So probably some different genotype may be responsible, or some other, this type of the explanation. Is it possible? And I think that is the reason that we should go for the details for the investigations for such outbreaks, so that exactly we can come to know that is it really some different genotypes, or really which may not be in our vaccine also. So what is your thought?
Baldev, that's a real thought out of the box. I had never thought of it that way, whether we should look at genotypes and whether the vaccine that is available covers all the genotypes. But if you look at the data from the Western world, they have managed to control mumps by high immunization coverage with the current vaccine.
Right.
So I would find it very unlikely that we have some special rare genotype only in this country to which our vaccine is not responding. I think the problem really is very poor coverage of the mumps vaccine.
Baldev, can I add?
Yes, yes.
Yeah, so there are 2 points. I think Dr. Prabhu has already mentioned about one, that what are the prerequisites for an outbreak of diseases like mumps? Most important thing, and even America, in spite of giving 2 doses of vaccines, they are finding outbreak.
Anyway, Dr. Upendra, with that point, you can take it even this addition of the question, that in spite of even the vaccination, I think most of the patients are not vaccinated, agree. What Dr. Shivananda mentioned, Dr. Suhas mentioned, and all of us, I will say no. But some of the patients, I'm sure, whatever the few patients have received the vaccine, I'm sure you must have come across that in spite of 1 dose, 2 doses, even sometimes 3 doses, and still they develop this type of the mumps, clinically what we say. So what are your explanations for all the situations?
So what are the prerequisites for an outbreak of disease like mumps? I think most important is high population density, extremely important, a very close contact, intense exposure, and prolonged person-to-person contact. So this is a must, and all of them have been responsible. I'll just quote one case in America, how they investigate the cases. There was an outbreak of 35,000 patients in 1 year in 2010. And it was marked that one 11-year-old boy, a US citizen, had gone to UK for a summer camp, came back, and he was responsible for doing this outbreak. So that is what they do. And here we are supposed to not
I think, Dr. Upendra, for them it is easy to locate. For us, that is not the situation.
Impossible.
Yeah.
Impossible. So what are the vaccine also? So we must understand what are the shortcomings of the vaccine also. So there are important pointers, that low antibody titer, that is very important. The neutralizing as well as non-neutralizing antibody titers, both are low. Poor antibody quality. So what is important is avidity. So it is considered that low avidity antibodies are responsible for not giving a great kind of safety and protection for that child. It is considered by the age of 18 years, 35% of our children, they're almost susceptible to mumps. So 35% is a huge percentage. That's why you had those 64-year-old, 25-year-old, all of them having mumps. That there is low avidity, and along with it, failure to generate strong B cell response. So that is another thing which is responsible. So there is absence of wild type virus to boost immune response in vaccinated individuals. That is another reason. So poor antibody, poor avidity, no B cell immune response, and then of course the serotype replacement genotype replacement. In our vaccine that we are doing, the A type of vaccine, which is the genotype is there, and what they have found in America, it is entirely different. The Sheffield strain that they have found, which is not a G type. So in vaccine, we have a A type genotype, but the outbreak is responsible, which is causing this outbreak, is entirely different. So which is not there in the vaccine, but this can only happen only when intense exposure is there. So unless and until you that, so that's why in America they could manage. So right now they give their first dose after first birthday. They give their second dose at 4.5 years. But now they have started that if there is an outbreak, probably they need to give in about 10 years later, maybe after a decade, that they may give additional dose. So countries are also trying to give more doses and probably a newer vaccine also.
Dr. Upendra, I will say a precise question and I want the precise answer. You know that the one dose of the vaccine may consider the primary failure.
Yes.
Second dose probably may be the waning of this immunity. But we say that usually after third dose, probably there is no hardly any excuse or explanation. And you know, occasionally, few numbers of cases, but I'm sure so many friends have come across that at each own place the 3 doses are completed, but still there are the mumps. What is the probable explanation scientific for this situation?
So these are the 2 reasons, probably low avidity of antibody, low immunity, so waning immunity, and on the background of probably we cannot call it that complete serotype replacement, and which is what is happening, the genotype replacement, which is responsible for that. But in a background of this, probably the immunity goes down, and that's why you are more susceptible. A low, as I said, the B cell response is much less as compared to what is expected. So immune memory cell response is also not there, because we are not yet sure exactly what kind of protection do we get after this kind of vaccination, whether it is a cell mediated response or an antibody response, which is giving a total protection. And that's why we are not sure about it.
Okay, I think now we have...
Dr. Baldev, can I add something? I have
one minute, Dr. Suhas. Two points I would like to remind all the panelists.
Okay.
Number is the watch. And second, Dr. Chetan flashes, I will say, box. That was the warning to us. Keeping in mind, I will say 5-10 minutes. Still we have the several points. Dr. Suhas, you can take your point, please.
Okay, my point is I have a very more simpler explanation for why we are seeing failure of... See, in the US, they give 2 doses starting after the first birthday. In our country, we are giving first dose at 9 months. While we know that there is interference with the measles vaccine, possibly there is some interference even with the production of antibodies to the mumps vaccine. So all our children are essentially, at least in the government sector, are receiving only 1 valid dose at 15 months, because the corporation or the public sector does not give a second dose at 5 years. That's what IAP recommends. So that's the reason why we are having a large number of population who is not immune.
Okay. I think you know that whenever somebody is talking vaccine,
point is,
sir, 1 minute. When we are discussing regarding the vaccine, wo Nitin bhai pragat hote hai. So I think now he's seen. I think Dr. Shivananda, wait for a minute. I think before we go to the next point, Dr. Nitin, a very clear explanation. And I think you might have seen, or some of our, so many friends talk to me that in spite of the 3 doses of the MMR vaccine, not giving the vaccine, not government, I will say included, is a different story, all of us accepting. But even in spite of the 3 doses, some of the patients, there are the mumps. What is the explanation and what we should do further?
So first of all, Dr. Shivananda, can I finish?
Please, sir.
Yeah.
Thank you. Sorry, sir. I'm the last barging person and given the first chance. Thank you.
I will just
first of all, I want to make it very clear. Let's see. We have an example of Mumbai municipality giving MMR and not measles for more than 2 decades. Okay, and it was part of the program of municipality in Mumbai till MR campaign started.
Yes.
After MR campaign, we had to shift to MR, and I asked the authorities why. They said they have to sync with the national program. Now, they felt that measles alone was not enough, so they have wanted to give rubella. And you know, Bombay municipality, the coverages are very high, even in slums. So they were not worried about congenital rubella syndrome having a reciprocal increase because of the substandard coverage. So they used to give MMR, and we hardly see any mumps during this outbreak in Mumbai patients. Okay. Whereas Navi Mumbai Thana, rampant number, entire country rampant. So first of all, mumps vaccine works. So that is the first presumption. Now the second presumption is how many doses and when. Now there were studies by Dr. Jacob Jones group where they studied giving MMR at 9 months versus 12 months or thereafter, and they found that as the transplasmal maternal antibodies can persist up to 12 months, if you give mumps vaccine before 12 months, it may not work as well as given after 12 months. But subsequently, there were at least 2 or 3 studies, not only from India, but even abroad, which actually showed that there is absolutely no interference if you give it at 9 months, provided you're going to give 1 or 2 more doses later. So that was the premises by which Dr. Vipin Vasishtha's committee had actually recommended MMR at 9 months. There were a lot of hue and cry that time that what is the point? Mumps will not work. Okay. So that time, remember, it was only 9 months MMR and 15 months MMR. 5 years was not there. Because the hue and cry was made that mumps may not work at 9 months. If you give only 15 months, 1 dose, technically you are giving only 1 dose. And there was a WHO position paper till then that you should give mumps only beyond 12 months. So they added 1 more at 5 years. And that's how we have now 3 MMR, 9 months, 15 months and 5 years. So now the question is that we are not seeing mumps in India in children who have received 3 doses to a large extent, unlike in USA. Now remember, in USA, if you are seeing mumps outbreak after 2 doses of MMR, not 3, because the 2 doses are at 12 months and 15 to 18 months. Obviously, they are going to see, because mumps is the most weak antigen of all the 3, and there is waning of immunity. And if you see, the mumps there, which is occurring in some areas, is in adolescents and young adults. It is not during childhood. So, which means the mumps vaccine is working to a large extent for the short term, like your WPAP story. So, let me finish. So, that's why in the areas, Jayan bhai, please, let me finish. Yeah. So, that's why in USA, only in areas where there is outbreak of mumps in adolescents and adults, they have introduced the 3rd dose MMR in adolescent and adults, not in the entire USA. And all these viral vaccines have periodicity of 3 to 4 years. Maybe without taking a 3rd dose as a universal dose in USA, the mumps will probably disappear. That is my gut feeling is. Now coming to India, when you are giving a 9 months MMR, you have a lot of seroconversion against mumps in many children. Some may not. You are giving 1 more at 15 months and 1 at 5 years is as good as giving 3rd dose. So we are not likely to see mumps outbreak in our country in pediatric patients who have been given MMR in private practice with the correct 3 doses.
So I think the nutshell what message we give.
Yeah. So now last question. So last comment on what Dr. Kinjodekar said about the type A and
one line, Nitin bhai.
Yeah, 1 line saying that if there was a genotype replacement enough to lead to what you call an escape mutant of the virus, you should have seen mumps even in vaccinated children. Whereas only in adults means it is waning of immunity and nothing to do with the antibody not protecting the current virus strain.
So I think point is very clear that if you go for probably the 3 doses of the mumps vaccine, probably we should not face the problem. Anywhere, if at all, occasionally, probably some scientific reason, but may not be that important issue for the vaccine. I think the point is clear. Dr. Shivananda and then Dr. Jayant. And Dr. Chetan has appeared. So I think within 5-10 minutes, we'll have to wind up.
Dr. Baldev.
Yes, sir.
See, in India, 80% of the immunization coverage is taken by the government sector.
Yeah.
Only to 15-20% is taken about by the private sector.
Private.
In private sector, we are giving MMR, but we are not giving in 80% of the population. So naturally, susceptible pool of pool of for mumps is there, definitely there. Naturally, this behavior of any viral infection is a cycle of once in 3 to 4 years. When the susceptible pool increases in the community, naturally you can see the outbreaks or epidemics once in 3 years, cycle once in 3 years.
Yes.
But what we are seeing in the private sector is we are not seeing the cases of mumps among the children who have been vaccinated with 2 doses or 3 doses. So naturally, we are giving 3 doses as it is. And we are not seeing many cases beyond 3 years, especially when they are using 3 doses. Naturally, whatever Satish put it, so we are recommending 3 doses. We are giving them. We don't see many cases. We are seeing only in the cases of mumps in unvaccinated children.
Yeah. I think, Dr. Swasthram, some friends are asking the question that suppose child has received the 2 MR doses at the National Immunization Program, and now they have come to know with this outbreak that mumps should be covered. And suppose child is brought to you, how we can go for the mumps coverage with the MMR vaccine?
Many parents were anxiously coming because they heard of these mumps out
so
there.
how we should advise them?
We will have to give them MMR vaccine. There is no option because mumps.
How many doses?
I would give 2 doses 3 months apart.
Right. So I think that will be the good practical solution. And one more question, Dr. Upendra, you can take it. That in this outbreak, suppose some unprotected child, they come for this vaccination. Is it possible that if you go for the MMR vaccine, you can offer the protection? Already, suppose some nearby children is already having this mumps, and the child is brought to you, unvaccinated.
The way measles and rubella can protect, mumps does not have that post-exposure protection so much in the outbreak setting.
Yeah, I think this is very important point which I wanted to convey, that yes, with measles it is known, but somehow I came even from the literature also, and it is not recovered. That may not be even you are going to get the benefits from the post-exposure vaccination also.
And Dr. Baldev,
Yes,
scientifically, even 2 doses 4 weeks apart are also fine. If you want to finish 2 doses of MMR, so 4 weeks apart are also.
Yeah, I think Dr. Jayant had some question or comment.
No, just to what Dr. Nitin Bhai mentioned was just to add to that you can give another dose at adolescent age group that is being started in some parts of US now. And second thing is that there is another technical difficulty why post-exposure would probably be not useful here is because the virus circulation in case of mumps begins much earlier before the presentation. That's why your probable vaccine efficacy would not be that relevant in that particular situation. But within 48 hours of exposure, it is worthwhile giving. Suppose there are 2 children in a family, one is suffering, and if you want to seriously prevent, because though vaccination has its own limitations in terms of efficacy and long-term protection, what we know is basically the chances of complications are much less in a vaccinated child.
Okay, got it. Dr. Upendra, I think looking at the data which I was showing from my college, one of the faculty asked, very young lady, that I should go for this vaccination MMR.
Yes.
The lady?
Yeah.
Yes, she can, but she should not plan pregnancy.
What I mean to say, she is quite senior person, about 50 or so. But when she came to know regarding the data that even the adult 60 years, even there were the mumps. From that reference, she asked me the question. I will say not male or female, any person of that age.
Absolutely, because see, right now we are considering only about mumps, because mumps does not come as a standalone vaccine. It all over the world it is available only as MMR vaccine. So if she has to take all the 3 components of the vaccine, so that she has to understand the chances of she getting measles or rubella or wants to have protection, but she wants to have protection against mumps. I think this is perfectly all right. She is justified in taking a vaccine.
Dr. Suhas, what you will advise? And how many doses?
Will it not be off-label? I'm not sure MMR.
Correct.
It will be off-label use, so you'll have to look at the patient's risk. I mean,
that's why I asked that probably this is not extended to that age.
Exactly. So off-label.
But sir, in US also, sir, 1 minute, for CDC recommendation also for healthcare professionals, irrespective of age, they recommend MMR vaccine.
Is it so for our immunization committee?
Healthcare professionals also. So I was going to ask a question to Dr. Nitin Bhai, that whether like how we all should take pneumococcal vaccine beyond the age of 50 years, or now even Chingri is coming, that do we all need to take MMR also? Dr. Suhas sir, I wanted to ask you one query. While we were during the pandemic period, there was an idea of giving MMR vaccine as a cross protection. Was that really attempted?
No, it was not.
No.
I think that was discredited.
It is not there at all. I think all these points have become very clear. BCG and MMR and everything.
Yes.
Anyway, I think there may be some of the issues. Everything very difficult to, I would say, complete in 60 minutes or so. But still, I will appreciate all the 4 learned panelists. They helped very nicely to be very precise even. They answered very shortly, looking at me and probably looking at Chetan.
Baldev bhai, may I bargain?
Sir, I was waiting at why this voice is not coming.
No,
I think now this is... Yes,
I was
please.
just waiting to be heard. My colleagues have said thousands of cases. I have seen publication, thousands of cases. But in reading in between the lines, I could not find what evidence have we given. Let me say I am a government and my switching from MR to MMR is 3 or 4 times the cost of an MR vaccine program. All of you are committing on our behalf that there is a pan-India outbreak. We have a highly immunized population in Delhi with MMR in the EPI, lately replaced by MR because of a government supply.
But we did not
see an outbreak. We did not see an outbreak. Yet people are commenting on our behalf. Number 2, thousands of cases reported. Sivananda has seen 150 cases. There are only 2 evidences. Either you give us a virological proof, which none of us has really done, except for Pune, what Jayant Joshi and Jitendra Gawane, you were listing that they had a spurt in meningoencephalitis.
Yeah.
Did any one of us, including Shivananda, 150 cases, Neminathan, lot of cases, Navi Mumbai, lot of cases, was there a spurt in clustering of cases in schools because it has got a reasonably good productive number as far as transmission is concerned? Was there a clustering or increase in any of the complications put together, which is good about 1 to 5%? So, I mean, was there any increase in acute abdomen? Was there any increase in orchitis? None of us really know. We have no age-specific data on outbreaks. So if I was a government, what do you tell me? Why should I put MMR? You have not given me evidence except that you clinically felt it is a parotid swelling and assumed that it is MMR. So, I expected Dr. Pankaj Prajapati, you are an evidence-based man. Tell me thousands of cases reported pan-India. You tell me 10% of them were virologically confirmed. I would stop my comments and believe
yes,
that
yes,
cases
sir.
made
I'm coming to your point. And
yeah.
I was expecting that this point should come in the discussion. If for nobody else, Dr. Chitkara is going to bring it. And I think it's a very, very valid question. Very valid question. Actually, in my take-home message also, I've taken this point. We can at least, what we can start, we can gather this data, whatever we have. And number one, as you said, probably maybe most of them clinical, but not all clinical. When probably we face a problem with the complication or something, we have at least some evidences of laboratory investigations also. May not be all, but to some part. And then probably we can take that with these mumps, those who develop this complication, yes, they showed this presence of mumps virus. And then we presume that whatever we have not investigated, but similar clinical picture, we can extrapolate that likely the mumps. We can say likely. And
sir, how many have you proved? Simple question. How many have you proved out of thousands?
Sir, that is my suggestion. That is my suggestion. In the last, I will say take a message that we can start it to the ID chapter. That is the homework for the ID chapter. That we can start to collect. It is scattered at present. Even in the last 10 days or so, I tried very few centers, very few places, but significant, I would say I have got it. And that probably we can gather even, then we can try to understand that how much it is important, how much it is significant, whether we have any point to say, to suggest to the government or some authority, that probably it requires some work and homework and analysis, and then we can come to the conclusion. But
sir, yet Indian pediatrics published 2 articles on mumps outbreak, and there is no evidence to be found. It is very difficult to get for you and me to get an article published in Indian Pediatrics Mouth Organ. Yet these institutions and opposition papers are being published with no evidence based. So I sometimes wonder, we are probably selective. We are going back into the Stone Age when we say, "Arey, मैंने कह दिया तो mumps है." ऐसा नहीं है. ऐसा नहीं है.
Dr. Chitkara, I will not take it that way. Definitely we know the stage or level, but I think whatever stage or level, on that ground, whatever we can do, definitely we'll do and try to come to this conclusion. I accept it. We have certain limitations, or I will say we don't have the exact information, but whatever we have, we can start from that and we'll try to go further. I think Dr. Chetan will have to end over here from our discussion. We can take the question answers and even the further.
I would like to take a few questions from the YouTube, because majority of your friends are on YouTube.
Yes, please take.
Who are not directly being connected. So just quick answers.
Yes, yes.
The question from Dr. K.U. Mahajan, that we have seen many breakthrough cases even after 2 doses of MMR in Pune, where vaccine coverage is good. So that is one report. Then Dr. Deepika Rajendran is asking, amoxicillin exacerbate mumps. Is it true?
No. No such thing.
No. Okay. Then Dr. Rupali ma'am is asking, question was, is it an epidemic or not?
Dr. Upendra, I think by definition.
Yes, it was an epidemic. It was an epidemic at many places.
Okay. How common is the mumps encephalitis? Dr. Charul Mehta is asking. I think we have many, I think as Dr. Upendra referred, Dr. Jitendra Bhawan series.
Dr. Chetan, probably not exact incidence of percent that we can give, but what we gather the information, yes, significant numbers of the patients, and that's why I think we can gather the total and we'll come to know.
Okay.
But yes, it is there.
Yeah, Dr. Sunil Kinwasara is asking, how common is the mumps polyarthritis and what is the management?
Dr. Swas, have you come across
I have not
polyarthritis?
seen-
Somehow?
Uncommon.
I have
Only
not seen
theoretical.
it. It is listed in the book, but I've never seen a case.
Yeah.
It must be quite rare. So also, for example, myocarditis has been described, but I have
Yeah.
never seen a case.
Dr. Sukumar sir is asking, Sukumar Palaniswamy, diabetes, is it a risk after mumps?
Yes, it has
No.
been reported, but there is no correlation.
Yeah.
Positive relation has been found out.
Dr. Venkateswar Rao is giving the one information that poor oral hygiene can contribute to bacterial parotitis.
Bacterial.
It
So
can cause parotitis.
that's a purulent parotitis, which Dr. Prabhu was mentioning.
Yeah.
Yes.
Okay.
Even staphylococcal infection is known. And that may be
Staphylococcal
part of
infection
it.
is quite common.
Is it possible that mumps complication hearing loss?
Yes, it is known.
Yes,
It is
yes,
known.
It is there.
It is
Yes.
there.
Typically unilateral and reversible.
Yes, yes.
It is
No,
temporary.
actually-
It is temporary.
So I like to give an important point regarding
Yeah.
deafness. As per
Yes, sir. Yes,
textbook
sir.
of
Dr.
Finnish-
Neminathan. Dr. Neminathan,
Yes, sir.
please.
Yes, sir. Can I proceed, sir?
Yes, sir. Please take.
Yes, sir. As per the textbook of Finn and Cherry of infectious disease in pediatrics, the incidence of deafness is 0.5% to 5%, and it is unilateral and it is permanent. Please remember, it is permanent. So the incidence is very low, 0.5% to 5%, but you have to remember it is unilateral and permanent.
Sir, it is reversible also been reported. It's
It is
not-
reversible.
Dr. Upendra, it may be reversible in most of the patients, but
Yeah.
some may go for the irreversible. What percentage he gave?
But deafness is not reversible. Whenever there is a unilateral, especially that
Yeah,
for some outbreaks have recorded 4% incidence of deafness,
right.
but unilateral, not reversible.
So, Dr. Chetan, at least this definitely is a significant problem. In short, we should keep in mind. Yes.
Can we give MMR to adults? That was, I think,
Already, I think we discussed
off the label.
off the label.
Dr. Sheikh is asking, any prophylactic antibiotics
No,
for
No.
prevention of mumps?
no.
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 Not mumps and for other conditions also, please.
Not prophylactic, not therapeutic.
Except defined.
Yes.
Prophylactic bhi nahi, therapeutic bhi nahi. I think
Yes.
before I conclude, Dr. Prajapati, I would like to differ from Dr. Amarjit Chitkara's comment of diagnosis, because in a OPD patient, typical OPD patient, when we are certain about the diagnosis of mumps, parotitis, there is no need to show documented that this child has definitely had, and I want to show all 100 patients were positive by this stage. It comes with a cost and patient. My treatment is not going to differ. But I definitely agree that every complicated case, we must have the
Must be.
diagnosis.
I think
that is
Dr.
what we should do.
Upendra, what he, I would say, wants to convey and what I believe or understand may not be all the patient, but to say that yes, it is the mumps, at least some patients, suppose if you are investigated and if you have come to know that yes, this is the strain or this is the genotype, probably it will help for further workup and understanding. We take, I would say, smell of disease point or the point of understanding. May not be probably in all the patients here he wants to convey, but that he wants to convey to us that we should have some reason to accept it, that yes, it is the mumps and nothing else. And for that, probably sporadically, suppose most of the centers, if 5, 10, 15 patients, if you have got it, probably it becomes a good evidence.
So, Dr. Upender, my comment is not to 100% investigations for all cases.
Yes.
My only submission is that if I have a spurt, at least I prove to 3, 4, 5% who are affording this test.
Absolutely.
And they are equally inquisitive to know whether it is mum, like I am interested to know whether it is mums or something else, which is a mimic kind of a thing, which you have named so many.
Sir, your point is absolutely valid and I'm with you and I believe it. 100%.
So we have Dr. Jitendra Gawande here.
Yes, sir. Dr.
So Jitendra, can you please share those 8
I
cases?
was just about to ask. There are 2 or 3 people like Dr. Palaniraman has put some figures.
Yeah.
And Jitendra Gawande and Dr. Ravi Shankar also. So if they can share whatever they comments they have put in the chat box, so it will be good for the audience.
Yes, please take it. Please take it.
Unmute. Thank you.
Yes, sir. Sir, I had one case which presented as typical history of fever and parotitis, and then altered sensitivity. and we thought it is a mumps and meningoencephalitis. We did CSF. CSF was showing 200 cells and 200 grams protein with a sugar of 50 with corresponding RBS of 150. So we thought it is a meningoencephalitis. We sent the viral panel to NIV. It came negative. CB-NAT was also negative, but MRI we did because its sensorium was not improving. It was showing basal exudates and developing Evans index was higher, so developing hydrocephalus as well. So I want to ask whether mumps flares the underlying tuberculoma into TBM or something like that, which we see with the measles cases, because this bacteriological evidence I didn't get about TB, but child required BP shunting also, and then now it gradually is improving in sensorium.
No, I think I answered this question in the chat box, Dr. Jitendra. It's not been reported that mumps exacerbates or flares of tuberculosis like is described for measles and pertussis. This might be just a coincidence, or maybe this is the first case.
Padmini Raman has asked very significant question, important question. What's the secondary attack rate of mumps?
Yeah, can I take it, sir? Yeah, the secondary attack rate is 85% in mumps, and a secondary attack rate means the number of persons who are susceptible to get mumps, those who get contacted with the index case. That is, if 100% people get contact to that mumps case, how many percent of them get mumps? That is called secondary attack rate. In mumps, it is very, very high. It is 85%.
That is okay, but the thing is, if person has suffered from mumps once, can he get a second time attack?
No, never.
That is not
Mumps
secondary
gives
attack.
lifelong immunity.
That is not
Mumps gives
secondary
lifelong.
attack.
Second attack is possible?
No, I'll tell you, some of the studies done in Manipal, that seroprevalence studies done in Manipal shows that the whole society is naive to mumps. If you, irrespective of the age, mumps does not spare any age. So when there is a contact, whether it is a child or an adult or a person who has taken MR vaccine in the government sector, whoever it is, the total secondary attack rate is 85%.
So Dr.
Hello, can you tell me,
Dr. Neminathan, with this 85%
I want to intervene,
secondary
yeah.
attack rate, we should have expected some clustering in the schools or play groups, wherever this index case has happened. But I am yet to find that any report of such kind of an outbreak with an 85% secondary attack rate.
So this is from, once again, I like to quote Finan Cherry, sir. In our hospital, we had a couple of many cases that came to us, particularly these 2 months, nearly on an average 1 case per day, around 60 cases in the past 60 days. And we took, our PGs took a history. Most of them during this April, May summer vacation, most of them went to the water theme parks. Majority of them went to water theme parks, and many of them went to crowded places like cinema hall, or there was history because of the school vacation. And we had a similar rise in 2016. As per textbooks, once in 5 to 10 years, you get mumps outbreak. But in Tamil Nadu, we had once in 2016. Now we are having it, sir.
I think what Dr. Neminathan is referring that it must be probably because of the asymptomatic infection. I don't think that is a clinical or symptomatic infection is 85%.
Yes, sir. When you look at the mumps as such, there are 5 types of presentation. Number 1 is asymptomatic seroconverters. They don't have any symptoms at all. Second is undifferentiated presentation. They go to the doctor with a URI, LRI, cough, cold, skin rash, arthritis. Neither the doctor nor the patient knows. Third is the most important thing, which is 75%. That is, they have classical mumps parotitis without complication, 75%. And the fourth is mumps with complication, that is around 15%. Then the last one is they don't have parotitis, they have complication. That's a money school. So these are the 5 types of presentation.
Now, I must add that parotitis is seen in only about 1/3 of cases. 2/3 of cases, there is no parotitis.
Yes, sir. 30% of the mumps, 30% of the mumps do not present with parotitis. And as you rightly told, all parotitis are not due to mumps. You
Yeah,
must
not
remember
due to
this.
mumps. Yes.
So,
Yeah.
Dr. Neminathan, most of these
Yes.
complications would occur in 2 weeks. So, did you find a spurt in any of the complication of mumps put collectively together in your
Yes, sir.
institution, which
Yes, sir.
sees
We
almost
had a
1
spurt
case?
of complications, sir. In the 60 cases, we had 6 admissions per month, out of which 2 cases of meningoencephalitis. Those 2 cases we proved RT-PCR, and we had 1 child with ascending polyradiculitis, 1 child with cerebellar ataxia, 1 child with facial palsy. All these cases we proved by doing CSF PCR. And we had 1 adolescent boy with an orchitis. He had a severe pain and he presented to us with orchitis, and he was referred to us for torsion testis, but he did not have a mumps history in the past. But when we did the RT-PCR, we found out that he had a mumps, sir. And this child with orchitis, what we did was we thought of viruria in the urine, and we did urine RT-PCR was positive for mumps. The
I
child with
accept your
orchitis.
explanation, but similar explanation is wanted from all of my colleagues who have
Yes.
reported elsewhere. I accept Dr. Neminathan and really believe if you had somewhere increased 3-4% of these cases had complications, I believe it was mumps. Strongly believe that.
Dr.
But what
Chitkara.
about others who have been reporting?
Dr. Chitkara, if I inform, during this week, I even talked personally to 4 to 6 ICU unit people, those who are working there in Ahmedabad. And I got these 6 to 7 patients hospitalized for this meningoencephalitis. They are confirmed with the CSF PCR. That at least I would say not recorded, reported, or published, but at least when talking to them, and even they showed, some of the parents showed even the report to me on the WhatsApp that yes, sir, this was the CSF PCR was positive. So I think we have some evidences scattered, not gathered, not documented, not tabulated methodologically, but that I think exercise is required to satisfy Dr. Chitkara and the friends, like I would say, naturally for scientific explanation. Certainly, I think it requires, probably we have, but we don't have this methodological collection.
So till that time, we should not go for MMR vaccine as far as the government is concerned on a universal vaccination schedule.
Yeah, I think we'll gather this data and probably will send to the office, and office will probably try. We hope that this ID chapter office bearers will take it. Dr. Chetan, I think comments from some friend, Pallani Raman, you say.
Anyone wants to comment or give some data? Dr. Ravi Shankar, he was having some data. Or Dr. Pallani Raman?
Dr. Bala is there? Dr. Bala, any comment from Dr. Bala?
Yeah, Dr. Ravi Shankar is there.
Yes, Dr. Ravi Shankar.
I didn't have much cases like what others having 50 or 60. I had only some 5 cases, out of which I could do RT-PCR by saliva and in urine and IgM capture ELISA test. 3 cases came positive, and one of the interesting was he had parotitis and saliva PCR positive for mumps, and same time he developed appendicitis. Appendicitis was proved by the ultrasound. He had severe clinical features also, and also in that case the salivary PCR came positive, and later we did the IgM capture also, that also came positive. So that one case has an appendicitis due to the mumps. That is a proved case.
So Dr. Chetan, I think data is there, investigations are there, but in the individual's files. So I think probably if we collect it, it becomes a good collection probably having for this explanation.
Palani?
Yeah, out of 100 odd cases I had seen, around 17 presented with only with submandibular mumps. And Dr. Suhas Prabhu was telling about mainly the differentiating from the submandibular node versus submandibular gland. One observation I found with respect to submandibular mumps is the submandibular gland is little more posterior compared to the node, which is more anterior. This is the one thing which I found it clinically to be useful with respect to submandibular mumps.
Right.
And the only one complication I had is only one case of orchitis. Otherwise, 99 I had no complications.
Arthritis or orchitis?
Orchitis.
And that all the 5 cases were not immunized in my case.
Yeah, not immunized.
All the 5 cases are not immunized.
So similar things what we found in Ahmedabad here. Even I have a almost 70 odd cases of mumps, but majority of them, they were not vaccinated with mumps. They were vaccinated with MR. But at least I couldn't find any patient with a MMR vaccine given and they had this mumps cases. That was what I saw. Anyways, if there are no comments, it was really wonderful discussion.
I think Chetan, before we go further, let me give
yes
5 minutes or so.
Please,
I think before we go for this end of this discussion, it is one important message from each panelist.
Please.
Let me start from Dr. Shivananda. I hope sir is there.
Yeah, he's there, very much there.
Right.
Yeah, sir, very important message from you.
See, we see the mumps outbreaks are epidemic once in 3 years or once in 5 years.
Right.
Most of our diagnosis is based on the clinical medicine. But taking into consideration when we are putting actually the pressure on the government of India to introduce the MMR vaccine, we must have sufficient evidence, especially laboratory evidence or confirmed evidence, so that we can see that this is really a problem. Definitely, vaccine is available, is safe, and emergency also is there. But the problem is, you have to show to the government how far it is, especially the number of admissions and especially how much it costs to the government. And the vaccine cost compared to MR is almost 5 times. And morbidity, you have to demonstrate how severe morbidity is really a concern for in the national level. And there are so many issues. Suppose you give me a chance, I can discuss about 15 minutes regarding what is the foreign against the introduction of MMR vaccine in our country. The problem is, you have to make the government satisfied is you must give sufficient evidence.
Thank you, sir. Thank you.
The number of complications is really a problem or not. It has to be sure. In that way, IAP can play a role because IAP can have a IDSU now is there, now is active. Now let all IAP, especially the members, report to the IAP server, and then so that we can document the number of cases which we are seeing in our country.
Yes, I think very important.
Along with the complications, that definitely with that statistics, we can put a pressure on the government to introduce MMR.
Thank you, sir. Thank you. Thank you very much. I think crisp and short message, Dr. Suhas Prabhu, from you.
Okay, I just want to add to Dr. Shivananda that if you want to prevent mumps, vaccine is the only way for 2 reasons. One is because the infectivity period is preclinical. And secondly, as I already pointed out, the secondary attack rate is very high. So there is no way you can do any kind of masking or post-exposure prophylaxis or anything. Vaccination is the only way. So that's the first point. The second point is Dr. Shivananda has already brought it up. Chitkara has been saying that we have to tell the government. So first part is really to prove to the government that this is mumps. But more important, we really need to see what is the burden of this disease. Yeah. Number of cases doesn't necessarily appeal to the government. We need to see what are the serious complications and what is the mortality. That will be much more difficult to convince the government because all of us have said, yes, you get orchitis, it is rare, sterility is uncommon. Yes, you get meningoencephalitis, but almost all of them recover. Very rarely, yes, 0.5% will develop deafness. So the morbidity, mortality may not convince the government to give the vaccine. Cost effectiveness will have to be found out, and those kind of studies are very difficult to do.
Dr. Upendra.
Yeah, I think they've already said important things, but what I would like to focus upon is all of us need to train the healthcare providers for identifying mumps clinical diagnosis. Work has to be done not only limited to pediatricians, but general practitioners. Segregate that child. I think we need to be made public and teachers aware that it's highly contagious, infectious disease, and the child should not be sent to school at least for 5 to 7 days once he develops. Yeah. So that is very important.
That is very important.
Treat, and then finally improve diagnostic and ensure that every child is vaccinated. Even if we take that much care, I'm sure that we will be taking care of mumps in community.
Dr. Jain, 5 lines only, maximum 5 lines.
Yeah. So I think all the points are covered. What I would just like to emphasize is that whenever the government will take its own action about improvising to MMR vaccine, when the patient comes to us, we must emphasize the need of giving an extra dose of MMR vaccine in our clinic so as to ensure, because we all know and we have seen that the chances of complications are less in a vaccinated child. So whenever we come across a patient who is vaccinated at the government center, we must make it a point to emphasize to give that vaccine in our clinic and ensure that the child is protected further.
Thank you very much. I think
by the way,
last few lines from me.
by the way, only one comment.
Yes, baby, bolo.
Only thing that as far as the moms in a vaccinated child is concerned, the most important point that I've put in the chat box that the time since the dose is in varicella vaccine is a primary failure, but in the moms is a secondary failure, and that's why the time since vaccine dose is very, very important.
Yes. Please, I think this may be the
only one line, sir.
Dr. Neminath, yes, one line.
Yes, sir. There is a misuse of antibiotics in mums because
Absolutely.
whenever the child has abdominal pain or vomiting, the counts that is done shows a false rise in total count and polymorphs. That is due to stress, and many of them misuse antibiotics.
Absolutely.
So never give antibiotics in mums because counts is high.
Yeah. I think few lines which may be probably repetition, but very important to emphasize. As we discussed that the recent outbreak of the parotitis swelling in children in India is due to mumps, in which our clinical, we don't have the answer for Dr. Chitkara. Absolutely right, valid point. The burden of mumps remains high in the country like India, which do not have this routine mumps vaccine in our national immunization programs. Cyclical epidemic peaks at every 4 to 5 years for mumps is known, as it is known with other viral infections because of several known reasons of science we know. The current resurgence of the mumps in our country may be due to not inclusion of the mumps vaccine in the program is very important, which everybody emphasized. Maybe probably private practitioner, whatever we are offering the MMR vaccine, that also we could not during the COVID period do. Waning of the immunity in the vaccinated children may be the reason, and even different genotypes. Somehow I think we are not paying the attention, but that is also to be paid, may be responsible for the present outbreak. And for that reason, I think it should be investigated, as Dr. Chitkara emphasized, and I think very valid point. The huge burden of the disease has been reported in current outbreaks, which we should gather. The shift of the disease is told that children, adolescents, and even adults, which I shared some of the figures. Serious complications like meningoencephalitis, pancreatitis, orchitis, and hearing loss probably are important. The pediatrician should follow the standard protocols for diagnosis and not unnecessary antibiotics, what Dr. Neminathan was mentioning, very important. And even including this routine vaccination as the preventive measures, very important. And I think what we can do as a body, IAP should convince the government of India for including MMR vaccine with scientific data, and that instead of this MR vaccine, for that reason, we can provide the data. Dr. Chetan, Dr. Darura, sir, I think we can try to gather the scattered data in one particular book or file, which will show this exact idea of data regarding its morbidity, problems, and complications. And PIDA can take the responsibility to collect all these scientific informations to put in a proper analytic manner, probably which become the good presentation and maybe probably convincing to the authority. Strengthening the mumps surveillance system, all of us know, as Dr. Shivananda was emphasizing, we don't report, that is the biggest issue. Investigations for outbreaks, what Dr. Chitkara emphasized, I do believe we should investigate to some extent to produce the scientific data, identifying the genotypes, which we don't do, and the study even the vaccine efficacy in the different vaccine strains. Of course, public awareness and education is very important. We can learn even from other, which I came to know that even Egypt and other countries, how they tackle these type of the outbreaks, that we can study in details, and probably we can suggest these measures to our authority and these to our academic bodies. Thank you very much. I think at the end, I would like to express a word of gratitude to all the learned panelists, which really helped me a lot, very nicely, very precise, so scientific information, and I'm sure that probably purpose of our this 90 minutes discussion is solved. I should express our gratitude to the office bearers, particularly Dr. Daruru Ranganathan and Dr. Chetan Trivedi for imposing, I will say, this responsibility to our shoulder, and probably I hope that we have tried to meet their expectations. Thank you very much and good night. Over to you, Dr. Chetan.
Good night.
Thank you so much, sir.
Thank you.
A word of wisdom, last comment from Dr. Raghunath Darur, and then thanks by our treasurer, Dr. Yashwant Rao.
Sir, one observation what I wanted to share. All the people who have gone to the USA from Hyderabad, whom I have given MMR, more than they are 2000 in number, and I am following them. Even after 15 years, they did not suffer from mumps or chickenpox or from the measles or rubella. So that itself indicates that a 2 doses with a 1 month gap is the protection for mumps.
Our
Thank you, one
vaccine is
and
the
all.
best.
Sir?
Dr. Yashendra.
Our vaccine is the best, I said.
Yes.
Yashendra.
Yeah, good evening, everybody. I thank for participating in recent upsurge of mumps and parotitis. I thank Dr. Baldev Prajapati sir, Suhas Prabhu sir, Ravi Shankara, Dr. Shivananda, Dr. Upendra Kinjwadekar, and our esteemed members, Dr. Neminathan, Dr. Ravi Shankara, Dr. Chitkara sir, for taking 1.5 hour time and making it a successful one under our team PIDA 24. Thank you, one and all.
Thank you. Good night.
Thank you. Good night.
Thank you, Baldev bhai. Thank you, Daru.
Thank you.
Thank you.
Good
Thank
night.
you.
Thank you, Chetan. Thank you, Baldev bhai. Thank you so much.
Thank you, sir. Thank you.
Thank you, thank
Baldev
you.
sir. Thank you,
Good
Chetan
night.
sir. Thank you,
Yes.
Daru
Thank you,
sir.
Jitu, for sharing.
Thank you, everyone. Thank you.
Good night.
Thank you. Good night.
everybody.
Good night, everybody. Good night.
Good night.
Night.
पहला YouTube पर थी बंद कर दे. Live YouTube live stop कर दो.
How many, Chetan? How many participants?
More than 150.
Good. Very good.
You stop from YouTube, right?
Yeah.
380
Thank
views.
you. Good night.
380 views.
No, that is okay. YouTube you stop किया ना?
Okay. It's delayed, so it's still going on.
That's okay, fine. But you are top, right?
Yeah.
Okay, fine.
Yeah.
Now you can.
Good night, Chetan. Good night,
Good
Manish.
night. Good night.
Good night. Good night. Good night.